Thanks, Harry. Good afternoon to all of you, and hope you had a light lunch because this might be a pretty long session. So, as Harry mentioned, so I'm hoping you can hear me well in the back. So as Harry mentioned, the focus of NIBIB is more into the biomedical imaging and bioengineering. And what I'm presenting here is mainly an overview of where NIH comes from and where our interests are, and also like points of contact within NIBIB who might be useful as you go forward in getting funding or working on your research projects. So the one thing people forget is that NIH is not one institute, it's the National Institutes of Health. So we are actually 27 institutes and centers, and we also have several offices. And the institutes and their centers have their own specific mission and focuses driven by Congress and mandated upon each institute. And they have to go by that mission statement that this is what we are funding and this is what is at the end the metric of how we are successful as an institute. So first of all, each institute has its own budget within the whole spectrum, and that gets decided by Congress, like this institute has to have this much money and XYZ. Then the priorities are different for what you want to do, and we have several institutes which are very focused on disease or organs, like for example, the Cancer Institute is focused on cancer, obviously, and then the Eye Institute is focused only on the eye. And on the other hand, we have institutes like NIBIB and NIGMS and NCATS. So these are focused more on the broader spectrum of sciences. And so NIBIB looks more at the engineering and biomedical sort of focus, which is where you all come in for. And NIGMS looks at more of the general medical sciences. The advantage of going there, for example, is looking at high performance computing. If you were trying to do something like that, then NIGMS may be a good place to go. Or if you're doing microscopy in this room, the interest might not necessarily fit with NIGMS, but that's one potential area of looking. And the last broad scope center or institute is the NCATS, which is for advancing translational science. It's one of the newer institutes at NIH. If you look at how the NIH budget is made, it's about $32 billion, which looks like a lot, but actually we end up, the money goes over very quickly. It comes in and goes out very fast, and that's mainly because of people like you who are exceedingly gifted at coming up with great ideas to solve problems in the biomedical space. And the graph here shows how it's divvied up amongst the various institutes and centers. NCI gets a major chunk of it, because obviously cancer is such a tough problem to solve and or to tackle rather. And NIBIB is towards the lower end of the spectrum. We are about 1% of the budget. And I think the thing that I think our IC director always tells is that we have 1% of the budget, we get 10% of the applications. So it's kind of it's a tough call when you're trying to fund applications. We get so many good applications. You have to make a judgment call at some point as to which science is worth funding more than another science. So the NIBIB budget is about $330 million. And the thing we always tell our investigators or applicants is that people always come up with crazy ideas, new ideas, innovative ideas. The problem is not that. The problem is how many of those are actually useful ideas, right? And when we say useful, you're not talking in the broad scope of utility like a patent, but more like how does it actually benefit the health of the US taxpayer or the improves health in the United States. And so, I mean, this is a cartoon that my colleague gave me. It's like you have a fork which is twisted, which might be useful, or it's pretty innovative. But if you look at the prongs of the fork, they're pointing in opposite directions, it's pretty much useless. So when you're coming up with a new idea, make sure that even though it sounds good and your colleague says the greatest idea since sliced bread, make sure that actually is useful for the people who you're going to treat or help. And again, our institute is focused more on like the technology as well as like how to develop new tools and new approaches. So we are more, the way I explain it to my investigators is that we are sort of like the bridge between the National Science Foundation and the rest of NIH. So we are a pipeline for new ideas which may have been developed outside of the biomedical arena, bring it into biomedical arena, and you clear it through our funding systems, and then you push it downstream through the downstream clinical institutes like NCI or NHLBI or on those institutes. So even in telemedicine, if you're developing new approaches like in mobile-based informatics, you may want to develop the technology and make it mature in our institute and then take it further downstream to actually implementing it with a clinical population, for example. The institute has a pretty broad range of interests, and so as I was mentioning, if you looked at NCI or say NHLBI, we're very focused on it's got to be the heart, lung, or blood, or if it's something else, we're not interested. In our case, we are pretty much interested in a broad spectrum of things. And then you look at our budget, you can realize what kind of quandary we have in that we have so wide a range of interests and we have a limited budget, so we had to figure out what interests are relevant at this particular time and how the review committees or the council of NIBIB feel about it. Some of the interests here which might be relevant to this community are like connected health, the biomedical imaging informatics, and mobile informatics. I feel some of the point-of-care technologies that we are focused in fit in, say, optical imaging or microfluidics and even sensor development technologies. We fund a lot of work in pediatric asthma research, developing new mobile-based sensors or wearable sensors for that space. We also fund a lot of work in prosthetics and in neurorehabilitation, sort of like using those kind of technology like brain-computer interface. So as you can see, if your interest is in any of these areas, please do contact us, and we'd be more than happy to talk to you and see how we can help you get funded. If you look at the point of care funding across the NIH, which is pretty diverse. I mean, the majority of the funding is from NCI, which is basically focused not just on the US, but also like looking at global health and developing technologies which can be used in lesser developed situations. But NIBIB is the second largest funder in that space. So considering our budget, we are actually putting a large percentage of our budget in point of care technologies.
So you're the second highest institute?
Yes, right now, this was, I think, 2016, September 2016. Yes?
Can you clarify by what you, for those of us who are a little new to the game, what point of care funding is and how that's different from the other funding that your group does?
So point of care is a very interesting term because it depends on how we define point of care, right? I mean, so, and in our case, I think this is a very broad definition of point of care, it's basically like devices or systems which are being developed to be used either in the field or, for example, we have a technology for doing oral cancer treatment using optical coherence tomography. It's a portable device which goes out into the field. So that's sort of considered part of care also. So in that sense, it's not just telemedicine, like how you would define like teleinformatics, but it's more like everything which is at the point of taking care of the patient or used by the clinician sort of thing. So that's a more broad definition. So in this sense, this might be an over-exaggeration of how much actually goes into that field. Sorry.
A question for you on the National Library of Medicine and how the intersection between that. You see a lot of NLP and computer science work in that area. I don't know, does that intersect with your institute also?
So the intersection of NIBIB and NLM is a little bit interesting. The reason I'm hesitating to answer that question is because currently NILM is going through a reorientation of its strategic vision. It's trying to figure out how it wants to align going forward. So a little bit uncertainty exists on how NLM wants to move forward. But going back to your question about NLM and decision making, it's sort of a mixed bag in the sense that at NIH we typically don't silo out research. So for example, if an NLP application comes in, at some level, it's decided by the investigator. When we talk to investigators, we tell them, if you're applying to an initiative, you should always put more than one institute to apply to. So if you're applying to an IBIB and you put secondary as NLM, then when it comes in and goes through review and gets a fundable score, then both institutes can look at it. If the investigator only puts an IBIB and doesn't put NLM, then NLM doesn't have to look at it. So we cannot tell them to look at it if you want to. But you can ask them. And the other thing is if they're not signed on to the initiative, then they will not look at it. So if you're coming into a parent application, which is the next slide, so they can then look at it. So going back to your question about NLP, Typically, we give first right to refuse to NLM because we believe that they have the expertise to handle NLP more than we do. So we typically let them run first with it. If, on the other hand, if it's an application which we feel deserves to be funded and NLM cannot pick it up, we'll pick it up if you have the budget for it. So basically, if it's a good science and we have the money, any one of the institutes will pick it up. So, but again, it's based on that box of whether it's within the initiative and all those kind of boxes that it was check off. So, as I said, this slide is pretty much talking about the FOAs or the funding opportunities that we have, and that, I mean, I'm presuming most of you know about this, that the grants.gov is where you would go to. I mean, the only caveat to this is the new Other Transactions Authority that we now are using at NIH for several of our initiatives, and that's more like a DARPA-style opportunity approach, and that typically doesn't necessarily come into the grants.gov. That's usually done directly on a website and sent out by an email. So that's a totally different mechanism, and so right now it's only restricted to certain initiatives, and we'll see if it rolls out more through the 21st Century Cures Act or not. The other thing is, like, typically we encourage people to come into the parent announcement. For telehealth and all the informatics-related initiatives, we used to ask people to come in through several of our initiatives that we had rolled out through a program called BISTI, which is, let's say, Biomedical Informatics Science and Technology Initiative. And that was mainly done over the last about 10 years because we were worried that there was not enough study sections or review panels which are favorable to informatics. And over the last 2-3 years, as we've been looking at the data coming through the system, we're seeing that the review panels have got more, if I might say, educated, that informatics is useful. So now the applications coming into parent do as well, or if not better, than the applications that come into a BISTI initiative. So we encourage most people to come into the parent unless we see that there's a gap in the review panels. And so again, as I said, the gaps that we try to fill are usually either because we feel the review panels are not getting it, or if you feel that there's a scientific area that needs to be desperately addressed and we are not addressing it through a parent. And so we do have several different opportunities which you can look at. So if you are coming in for an RFA, I would strongly recommend that because usually RFAs have specific review panels tuned to look for the issues relevant to the RFA. So if we are coming in, it's definitely a strong argument to come for that. But when funding is tight, usually we have very few RFAs come out because it's hard to set aside money when your budgets are uncertain. So there are 3 different opportunities which I feel might be relevant here. These are basically like bioengineering programs, and we encourage a lot of people to apply for the BRP, which is the last program here, the 16-116. So this is basically a U mechanism, which is a cooperative agreement. It's not a grant. It's a cooperative agreement, and I can go into details if you want. But basically, this one allows you to work with multiple partners or work with industry and actually take something from where you are in academia to further downstream. For example, so BRP is locked in at 10 years max. It cannot be more than that. So it's not like an R01 where you can build a whole life into retirement out of an R01. But BRP is focused 10 years in or out, and you better have a product at the end of 10 years. And so and the budgets are higher for that, and they're 5 years instead of varying between 4 and 5. And so that's an opportunity which a lot of people don't take us up on, and I would encourage if you're working with, say, industrial partners and want to take a product downstream into the market, I would strongly encourage you to look into this mechanism. And the BRG and the first 2 mechanisms are the standard R01 and R21, which are focused mainly on bioengineering. So anything related to engineering aspects of things, I would encourage you to go into those 2 initiatives. The newest initiative that NIBIB started is called the Trailblazer, and a similar initiative has been started by NIGMS, and I forget what their acronym is, but you can Google for NIGMS Trailblazer, you'll get something similar. So the reason why we went down this road is that when the R21 mechanism was first introduced a few years back, the logic was that we wanted applications from investigators where they did not have enough preliminary data, and that they had some crazy idea and they wanted to try it out, and it was high risk, high reward. Unfortunately, what's happened over the time since we released that initial parent R21, the review panel also started looking for more data. So when you have one application which has some data, preliminary data, and one which has none, the one with preliminary data gets a better score. And then when the applications come through review to us, it's hard for us to argue to our scientific council that the one without data should be funded first, because the peers have judged the one with data as a better application, so we don't have a choice. So we said this is not what R21s are meant to be doing. They're supposed to be meant for taking risks and taking innovative ideas forward. And so if you have preliminary data, the risk is out of the window. And so that's why we released Trailblazer, which is about getting to a year now. So the data is still out there. I mean, we don't have enough data to know how well it's working, but it's quite interesting that it's more of a culture shift that we're starting to ask for from the community. And even now, even in this particular initiative where we clearly say we do not want data, the applications which have data are still getting scored better, which is really sad. So, and what we are doing is pretty much throwing them out. I mean, we're saying that we don't want this. Even if it scores better, we don't want this application. So if you have a good idea but you don't have data for it, come to the Trailblazer. The caveat is it's for younger investigators, so not just young at heart, but really young, new early-stage investigators. So we are looking to develop something which expands the scope to across the board, but this was our first trial out there to see how it floats. And I think there is a lot of interest in this scope, and we are probably going to move more towards this direction than towards staying with the parent, because I think the parent is not addressing what we want out of it. Again, the focus here is at NIBIB, we are really looking for high risk, high reward. And the only caveat to that is obviously you have to have a review panel which gets it. And so the institute does want it. So this is another initiative which is looking at reducing health disparities. And I think this would be another place where telehealth would definitely be of use. The initiative has expired, but we are working on reissuing it soon. Again, there is no, there was a set aside for this, but I suspect this may come out without a set aside in the next go round. So I've been told I got 5 minutes left. This is a cartoon that my colleague gave me, but basically, like, it's a classic engineering problem. I have done it so many times in my life. Like, I come up with this very cool idea, and I'm like, what the hell do I do with that? It's pretty nice, but it's not very useful. So, I mean, a lot of us go through this exercise of futility of coming up with something nice. And the one thing NIBIB really likes to do, and this is something we've been working closely with NSF, the National Science Foundation, on, is like encouraging interdisciplinary research. We believe that it's not just one community which can come up with the best idea. I think it's like when you have experts or people with different ways of looking at a problem, you can come up with the best solution or the worst solution. So the problem is that when people talk about, when you bring different disciplines together, at the minimum what you need is a translator, because somebody says big data. I mean, a clinician, big data, and a physicist, big data has totally different meanings. So when you have a conversation between these two communities, you want to make sure that we are talking the same language and we're saying the same words and we're meaning the same thing. And it is really hard. So we're trying to build that bridge. It's not easy because each community believes it's right. So it makes it harder, but we're trying. So the BRP kind of mechanism is a good way to start going down that road. So this is just the last few slides where I'm showing the names and faces of people who you can talk to at NIBIB. Chris Kelly heads our extramural program right now, and she is coming from the background of bioengineering. And the way NIBIB is structured is, even though it says divisions, there's no division as such. It's more of a uniform organization, and there's a lot of cross-fertilization of ideas. So we focus mainly on like discovery science or the applied sciences and the informatics, and also, we also have some multidisciplinary or interdisciplinary training. So Tiffany Lash, I think Hari mentioned, she's a person I think you would be a primary point of contact for telehealth and connected health programs. She's also managing our point of care network, and her information is out here. Ed Ramos is managing the health informatics portion of our portfolio. He's relatively new to the program, and I'd asked him today how does he define his program. He says it's pretty broad, and so if you, you can always talk to him. And he's mainly focused on the precision medicine initiative, which is now called the All of Us. He works more on the EHR and the mobile informatics, and he manages several of our mobile informatics data centers. Andrew White is a new program officer, and he's focusing more on the neuroinformatics, and this is again where the OT, or the transaction mechanism, is being used. And that's me, and I manage the bioinformatics, the biomedical imaging informatics, and citizen science is something we're getting involved in. So these are not the only people at NIBIB, we got more of them, but I figured you can remember these many, that's a good starting point. There's always Google to go back to, or I guess, Bing, I guess, is the next option. So call us up, email us, and we'll be glad to talk to you. Thanks.